We're getting a little summary today. Hello, everyone. Do I got my sound on? No, there we go. Hello, everyone. Little summary. Got my summer hat on, kind of looking a little more casual today. We're once again entering a heat wave over here in Chicago after a couple really nice days. But so I hope everyone's doing well. This is questions and answers with Dr. Makela, where I answer your questions about anything cannabis, geriatric medicine, hospice, all of these things. Throw in the questions and I'll do my best to answer it. So, welcome. I am here today. Last week I was off for the week. I had just a little tiny cyst removed from my head, but the surgeon could only do it on Wednesdays. What can you do? It's okay. It's all good. Glad to see everyone back again. I am here today. So, we're going to just talk a little bit about today. I want to talk a little bit about medicine and cannabis. Specifically, I posted today a question. I got a few answers on it, but I posted a question. Do you talk to your doctor about cannabis? If you use cannabis, do you tell your doctor or not? Now, me, I'm a doctor. It's like, yes, you should. Definitely. But I can understand a little hesitancy about it. In some states, it's illegal. There are still situations, for example, in states where it's illegal, where if a mother tests positive when she's in the hospital delivering a baby, where Child Protective Services gets called on her. And they don't do that if the mother's smoking, right? So cannabis, because it's illegal, they'll do that. And like that's not right. Now, there are questions you should have with your doctor, when you're pregnant. This type of open conversation, right, should have been happening even before then. But people get scared. And even outside of like a pregnancy, you get stories of just people being afraid that their doctor's going to yell at them or call the cops or there shouldn't be a doctor calling the cops. Again, with those stories about pregnant women notwithstanding. Generally speaking, if you go to your doctor's office and you tell them you use cannabis, they're not going to be calling the cops and saying, I found someone who uses cannabis. Um, Obviously, if you're in a state where it's legal, that's not going to happen. But also, generally, that's not going to happen. Even people who are using very strong illegal drugs like heroin and cocaine, I'm not calling the cops and saying, oh, they're using it and da da da. We have conversations. So now how would a doctor approach this? If someone said they use cannabis. Well, me as a doctor, if someone came to me and said it, I would do things like say, let's talk about how you're using it. Are you smoking it? Are you vaping it? Are you using edibles? Are you dabbing it? How much are you using? There's smoking, because you have combustion materials that you are smoking, there's always that risk that the stuff that actually burns, so not just the THC and the CBD and all that, but all of the other things that combust, that when you smoke could be potentially causing damage, that you might be having increased free radicals and increased damage. Now, I've said it before that there's a lot of studies that look at long-term use with cannabis. And when we do see bronchitis, which is a thickening of the airway tubes, chronic sort of irritated, it kind of gets irritated and swollen, and over time it can be chronically thickened and have mucus that increases with that. And so people can get these sort of mucousy coughs. That is a thing that can happen with using cannabis by smoking long term. We don't see a lot of data about lung cancer or COPD or emphysema like we do with cigarette smoking. And I think the simple truth is that when people cigarette smoke, they're smoking a pack a day. They are 2 packs a day even. So each pack is 20 cigarettes, so 20, 40 cigarettes in a day, right? A 2 pack a day habit. So if you're talking about that, that's a lot of products of things that are burning in you. So whereas someone who's smoking a joint, maybe, a very aggressive smoker is going to smoke a whole joint. But generally speaking, sometimes people just have a puff or two in a day. That's probably just by sheer nature of the fact that you're taking less of it in your lifetime is probably part of the reason we don't quite see all of the lung problems that we do with smoking weed as we do with smoking tobacco. However, generally, as a matter of good practice, us doctors are like, no, no, don't do that. So I would encourage people to not smoke. Now, some people, you know, the thing with smoking is it hits faster because you don't have what's called the first pass effect. Now, some of you probably already know this because you've researched cannabis, and so you know the difference between edibles and this. But for those who don't, if you smoke, it goes directly into your lungs, and then from your lungs, it goes into your bloodstream. So it immediately hits. Anything you eat, you have all these blood vessels from the stomach and the intestines, and they all join into this big vein called the portal vein. This portal vein goes into the liver, as in portal, like it's a portal to the liver from the stomach. So instead of going all the way through the body, it goes to the liver. The liver's job is then to detoxic. And so the liver does this great thing where it detoxes anything that we might be eating, any toxins that we eat. So this is why a lot of different drugs, for example, have what's called a first pass effect. In my world, in hospice, where I'm using a lot of opioids, even the opioids for morphine IV, where I don't have to worry about the first pass effect, is 3 times more potent than morphine if you take it as a pill. And so, because when you take it as a pill, 2/3 of it gets destroyed by the liver before it reaches the body. So that's the first pass effect. Now, in cannabis, an interesting thing happens because it not only gets converted from delta 9, it gets converted to a different cannabinoid that actually hits a little bit different. So some people have a different experience because I think it's delta 11 that it gets converted to in the liver. And because of that, people experience it differently. They have a different high. So that's one reason someone might say, I'd rather inhale it than take an edible. Now, and then of course, some people are like, I want it now. I want the feeling now. Now, there are some edible things, such as tinctures, where people put it in their mouth and kind of you put it in your cheek, in addition to under the tongue, under there. You can also put it right between the gum and right here, the lip, kind of like if you've ever seen anyone old do snuff, right where they, right there. That is a very vascular area. In fact, when at the end of life in hospice, when I'm giving people morphine, this is a place I'll often give morphine to people to kind of soak it in through the blood vessels here, just like the blood vessels under the tongue can absorb. So, for example, in Europe, the Stativex, the cannabis CBD prescription cannabis that's approved in Europe, when people take that, it's a sublingual spray. They take a spray and they put it under their tongue with the idea that it hits a little faster. In fact, some tinctures I find will hit faster. Again, I think some people might be getting a little bit of mucosal absorption, or maybe it just because it's a tincture, and a lot of times it's dissolved in fat or something, so it's a little bit quicker absorbed than say a gummy. The So you can get some things, and then speaking of gummies, especially from the beverage industry, they now have things like nano emulsified. There's a whole bunch of different tech out there where it's these emulsifications make tiny little droplets of the THC. And so it dissolves easier in stuff. And so as a result, it gets absorbed faster. And so they were developing it so you could put it into beverages and it would stay suspended in beverages and you wouldn't have to shake the beverage to make sure it wasn't all just settled at the bottom, because THC is very fatty and beverages, of course, are water based. And so you had that problem that these fatty particles, it's olive oil and water, right? It's oil and water. They don't mix. So they created some different techniques, nano emulsification, nano. I'm trying to remember, but there's another one where like they put little liposomal particles around it. There's a lot of different variations. Liposomal being fat, so it's they're fatty on the inside, so it connects to the THC that's fatty, and then it binds to water on the outside. So it's a little bubble, basically, that they encapsulate it. So nano encapsulation. And so there's some different ways they do that. Those, when they've done studies on these, people will often get a hit in 5-10 minutes. So just a warning, if you're kind of new to gummies and you get something that says nano encapsulated. There's actually a couple states that say you cannot claim it's fast acting. I find that a little concerning because then I'm like, oh, gee, you take it, you're expecting it's going to hit in an hour because everyone says gummies hit in the hour, but now 5 minutes later, you're starting to feel something. And what if you weren't ready? That's concerning. So if you ever do see anything that says like nano encapsulated, nano emulsified, or if you're drinking one of the beverages, be aware that that might hit a lot faster than a typical gummy, or typical edible. Now, why I say about that is, smoking. So there are some options if you're trying to just get hit faster. Like, let's say you have nausea. Let's say you do have symptoms. Let's say you have pain that you really need some relief from. There might be some edible formulations that can hit faster. The other option is there are vaporizations. So the common one is what was called a volcano was the first one out. And it was this thing, and it heats up dry flour until it reaches a certain point, and at that point, it doesn't burn it. So you don't get the side effects of burnt material in your lungs. But then what happens is after you burn it, it vaporizes. So the THC, the CBD, the terpenes, all of these volatile chemicals, these chemicals that can kind of go into the air, and then it has a little bag that you collect, and you can actually inhale the bag. Some people, one, that's it's kind of expensive. Two, the bag's kind of a pain. So there are companies now that are trying to make handheld versions of that, where people can just go puff into it. So those are some of the things. So as a doctor, yeah, I am going to say, please don't use smoked cannabis. And of course, you're not going to find a doctor or too many doctors that are going to actually endorse smoked. We all have memories in our head of seeing images from the 50s and 60s of doctors in their full lab coat smoking some camels and saying they're healthier because they're filtered. So That kind of image, that's gonna be one of the reasons your doc is not gonna do it. Plus yeah. Now, is your doc gonna yell at you? Probably not, and if your doc yells at you for smoking, maybe they're not the best match for you. But you wanna talk to them because cannabis can interact with medications. I know we've talked about that before, that there's a lot of different things. I told you it goes through the liver. One of the things that it does, though, is because it goes through the liver, there is an enzyme. There's actually a couple enzymes. One of them is cytochrome P450, which is a famous one because it interacts with a lot of drugs. But then there's a couple other enzymes. And these enzymes mean that it can affect how it breaks down other drugs. So if it's busy breaking down the cannabis, for example, it may not be available to break down your SSRI, your Paxil or whatnot. If it's or the body makes more of something to break it down. Now it has more, and now it breaks down more of the drug you're taking. So there's a lot of different ways that it can affect the liver because the livers can go into overdrive and say, I have to make more of this because I got to break all this down. And now you have more of it, but that drug also affects drug X that you're taking. And now that drug gets broken down a lot faster. So you need to talk to your doctor about that. Plus, there can be some physiologic side effects. We know that cannabis smoking can increase the blood pressure transiently, but then some people can have long-term decreases of their blood pressure up and down. So if you're on a blood pressure pill, particularly if you're really fragile, if you're on a really low or you're really high, if they're having a hard time getting your blood pressure down or your blood pressure is super low, and there are certain conditions where your overall health is better, and they say, yeah, we got to keep you super low. Certain heart conditions, for example, where a doctor would do that. We would say that we want to just kind of keep an eye on that. There are a couple meds that we would really be concerned about. There's a transplant medicine called tacrolimus, a little bit too much, and you can be very prone to infection lethal infections. I've actually had patients where they had too much in their system and then got a bad infection and died. And then you can have too little and you can reject your liver or your heart. You kind of need those to live. So if you have a transplant meds, especially if it's tacrolimus or sirolimus or one of them, they say that you could measure the levels a little bit more frequently to be okay, but that is definitely something you'd want to talk to your doctor about. In fact, I would say you'd have to have a good reason to be on cannabis, a very strong reason. I would strongly discourage someone with a transplant to use cannabis recreationally just because of the risk of that. The other thing that you might do is, of course, increase the risk of sedation. If you're already taking a lot of medicines that are sedative, you want to be aware just kind of how that can interact. So, a lot of these side effects. So, as a doctor, I'd be looking at that and I'd be saying, I want to know that you're taking this. Antidepressants can interact. Now, from what I understand of people who have studied this, it doesn't interact a ton. It may not be a clinically significant amount, but antidepressants can go up in your system. So if you take 20 milligrams of a pill, you might be taking the equivalent of a 25 milligram pill. Since the next one is 30 or 40, it's probably not the end of the world, but there are, for example, SSRIs. You do have a risk of a thing called serotonin syndrome, which is extremely rare bad side effect that can happen if you're taking a lot of drugs that can affect the serotonin system. So sertraline, which is an antipsychotic, is sometimes given in the same patient. So you can have a handful of different pills that have that effect. And now you go up a little bit. Yeah, it's not entirely benign, but again, you talk to your doctor. They may say, yeah, no, it's okay. We'll watch it. you'll be fine. The or they may say, "Hey, look out. If you start to notice this, this, and this, I want you to stop taking it and call me right away." Which is a lot of times what we'll do with drugs. Most drugs have side effects. If you've ever watched a drug ad, how many times when you watch a drug ad does it go, "Okay, you have take this and you'll have sunny days and it will do good things." And don't get me wrong, a lot of these drugs save lives and they do wonderful things. But then they list all the side effects. Now, me as a doctor, I look at those side effects and I say, okay, that's one in a million. That's one in this. That only happens in these people. That's not too and you judge it. You say, well, the risk of dying a heart attack is up here, and the risk of this particular side effect is here. So overall, the benefits outweigh the risks. And so you have a conversation, and I tell you, hey, this is what you look for. The pharmacist gives you a list of meds and says, this is what you look for. So there's always going to be some interactions. There's always going to be some side effects with the meds. So, yeah, you want to talk to your doctor and actually have that discussion so that they know, yeah, I take cannabis and I was told to just be careful about some drug interactions. Another one to be careful is blood thinners. Now, it seems like your newer blood thinners don't quite have the same interactions. Your things like your Eliquis and stuff don't seem to have as much interaction with cannabis. But not surprisingly, to anyone who's ever had to use it or knows about it, warfarin, which is the old school, very old blood thinner that you have to get tested every so many weeks, can go up or down. And there were some cases of people having rather notable jumps when they started using CBD. Now, this was prescription grade CBD in the Epidiolex trials. So these were people taking really high doses, but that interaction went up. CBD, for that matter, again, this is from the Epidiolex, had issues where people's liver enzymes went up. Now, they were benign. No one had severe liver failure or anything like that. But if you have liver disease, maybe you want to think twice about CBD. If you're taking valproic acid, especially if you're taking higher dose, that was one of these that interacted because they were using Epidiolex for seizures, and a lot of these people were also taking valproic because it was a very strong anti-seizure medicine, and they noticed that the liver stuff tended to happen more often in people taking valproic. So if you're taking valproic acid, be careful about CBD. Again, probably not in the lower doses, but you definitely want to talk to your doctor about it. Now, there are other, so yeah, be careful about that with the liver. So that's some of the interactions. That's one reason, drug meds, and the other one is talking about your risk factors. I had one poor gentleman who would smoke, and I was really trying to get him on gummies, yes, I admit, because every time he smoked, he had a history of smoking tobacco and did have chronic COPD. And it wasn't too bad, but every time he smoked, it would cause irritation. He'd go into a coughing spell and have to take his rescue medicines and almost be on the verge of needing an ER visit. I'm like, really? You need to start talking about taking gummies. He's like, oh, I tried. They didn't work. So those are some of the reasons you want to talk to your doctor. Drug interactions, it's interactions with your health to see what else. The other thing is, yes, a lot of doctors, they're going to be like, oh my gosh, it's an addiction because we have made the DSM-5 to be sort of have basically using it is almost mild. And it's not really using it. It's like, do you have tolerance? Do you use it every day? Those types of things. But there are situations where people are using it every day. They're kind of using higher doses. And it's not working as well as it used to. And now they're feeling like they're maybe a little bit more woozy or a little bit more sicker with it. And they're starting to wonder, am I taking too much? And that's actually one of the questions, right? Is, am I taking too much? That's actually a checkbox on if you're starting to ask, maybe you are. And that's where talking to someone, that's where talking to your doctor about that might be able to get you some help. There are some people who do things like there's a couple doctors out there who actually have protocols for decreasing the amount you take to sort of decrease your tolerance, tea breaks as they call them. I know Dr. Sulak has a protocol that he came up with years ago, and I think there's some other ones out there. But this is what you want to talk to the doctor about again. So I personally, I would want to know if my patients were using cannabis. And I think you shouldn't be afraid to talk to your doctor. Now, I think a lot of doctors don't know a lot about cannabis, and that's a bit of a concern. A lot of doctors don't know about cannabis, and so that is a something to know. And I'm actually working on that. I'm trying to develop some protocols, and not just really protocols, but some training sessions to teach doctors. What do you need to know? We don't want doctors just reflexively saying, oh, you're on cannabis. Oh, have you stopped? Do you use gummies? The other thing as a doctor, I would want to know is why are you using it? Because sometimes people are using cannabis to self-treat things that aren't being treated. So if I find out that, oh, you have an anxiety disorder, or oh, you're not sleeping well, or oh, you're having sexual, pelvic problems. These are all things that as a doctor, I would want to know. And I think it's important to tell me because maybe there's something else I can do. Maybe you're using this high dose of cannabis to try to help something that really could be better treated with something else. A classic example, I would say, is PTSD. Now, the evidence that cannabis helps PTSD is very good. I think there's really decent evidence that cannabis helps. It helps the nightmares. And yes, part of it's because it's messing up the REM sleep. You don't get as much REM, but if you get nightmares and all your REM is you waking up in a cold sweat because you keep having nightmares, maybe not having some REM is a decent thing. So it stops the nightmares. It helps with some of the anxiety in some people. Now, some people get more anxious and it's not a good choice for them. But some people, it helps their anxiety, it helps the PTSD, it helps that. And if I find out that you're using it and I say, well, why are you using it? What does it help with? The and you say, well, I had combat, back in Iraq, Afghanistan, whatnot, and now I have bad nightmares and I use cannabis and it helps me and it helps me relax and I can go out and live my life as opposed to staying home, and you tell me a story about how you used to have some sort of addiction and cannabis helped you overcome that. I'm going to be like, okay, not bad. Now, what I might do though is I would say, have you tried therapy? Have you tried cognitive behavior or EMDR therapy? Because those are evidence based treatments that can help. There are things that I might know about as a doctor that, you heard cannabis treats it, so you got it from the dispensary. You got it either from like an online medical card or you got it from just a recreational and started using it and it worked. So you kept using it. As a doctor, I want to know because I want to say, you know what? You keep doing that. That seems to be helping you. But let's see if we can't get you some therapy, some cognitive behavioral therapy or some to also help you deal with it. Because there is a difference, and I think this is important, between using cannabis to treat something that isn't being treated or that we don't have a good treatment for, and using cannabis to hide, to hide from everything, right? To say, I don't want to deal with this, and I'm just going to get toasted so I don't have to deal with it. That's not necessarily healthy. And that's actually a lesson I learned a long time ago when I was doing geriatrics. No, it's even before then. When I was back in residency, I was doing a rotation on sickle cell. And that was often a question for us about people who were using it, right? They were saying things like, well, they would come in and say, oh, I have pain. I hurt. I need Demerol. And that was back in the day when Demerol was used. And Demerol was more addictive than Oxy. It's just Oxy was used a lot more because everyone thought it wasn't. Everyone at least knew Demerol was addictive. And so Demerol was addictive. It was very strong. And you don't see it too much anymore. You still can get it, but it's not used as much. But that was what these kids with sickle cell would get to help their pain because it was effective. But they'd come in, and the question was, are they just addicts? Are they, you would see people and you would wonder, are they addicted to it or are they really in pain? Because, of course, pain's subjective and you don't know. And so one of my attendings gave me some of the best bit of advice on that. They said, is the person using it to live, or are they living to use it? And by that, if they're taking it, and they're taking it 6 times a day at these huge doses, but they're going to school and they're living their life and they're spending time, and this is keeping them out of pain, that is a good thing. If, however, they're getting panic attacks even at the thought that the pain might wear off, and they're like, oh, I got to take my next dose, or I need a higher dose, or I like how I feel when I'm on it. I want more. I want more. That becomes problematic where your life is built around getting the pain medicine versus the pain medicine helping you to live your life. And I think that's true with cannabis too, is that there's a lot of people who live to who live better, where their pain is better or their symptoms are better or whatever condition, their MS is better because of the cannabis. They're not using as much opioids, for example. We know this. We know people use less opioids. But there is an element of people who, again, they might be hiding from emotionally, hiding from their emotions that they're facing by using the cannabis because the cannabis makes you feel good. And I don't want to have to think about all the stuff that I'd have to think about if I did therapy. So that is what I mean. Now, then there are people, who there's the people who are self-medicating. I want to know that. Then there's the people who are using it recreational. Now, someone who uses it recreational periodically and is living their life okay, I'm not going to stand here in judgment and say, how dare you, then go home and have a martini myself, right? But what it becomes again is a problem. Is it your whole life? Is it taking away from things you love? Is it getting in the way of your family? Is it getting in the way of the job that you want to do? Is it getting in the way of the life you want to live? When those things happen, that's a problem. So as a doctor, again, I'm going to be harm reduction. I am going to say don't smoke. Then I'm gonna say, I'm gonna ask you a little bit about why you're using it. What benefits? And part of that is I wanna know because I wanna know if there's something I need to be treating or talking to you about treatment. Then I'm gonna screen to make sure there's not an addiction, that it's not a problem. And after all that, and then we'll talk about medication interactions. Is there any meds or any medical condition that we need to talk about that is getting in trouble? So, yeah, that's don't be afraid. I won't bite. And I don't think your doctor would either. I don't think most doctors these days are going to bite. If you have any horror stories, though, go ahead and put them in the comments. We can talk about it. And obviously, if you have questions, you know, put in here. Tell me, do you talk to your doctor? Go ahead, put in the comments here. Do you talk to your doctor about cannabis? Do you, or are you scared, or are you? Do you have thoughts on that? That's sort of one thing. Obviously that's if you use. If you don't use, that's a different story. Obviously you're not. But that's what I would say on that. Now, you know, as a doctor, one of the other things that annoys me, I think, is that us doctors really don't get a lot of teaching about cannabis. Anyone who's followed will have heard me go on and on and on about how doctors don't learn about the endocannabinoid system. And I think if they did, I think if we have, we would know. Uh, oh, someone says you have talked. So, hey, tell me what happened when you talked to your doctor. Were they accepting of it, or were they kind of mm, the? I wish I had like a way to do some real time raise your hands here on this, but to see if people have had negative experiences or if it's been pretty positive experiences when their doctors come in. But I have told people this before and I laugh because as a palliative doctor, even as a geriatrician, all these older baby boomers who had been using it forever and a day, the I have had more experience in general practice than most doctors with patients using cannabis. But the the thing that I kind of laugh about now, and it's kind of embarrassing to admit, for the longest time, I had thought that people smoked the leaf. There's a little leaf, right? That's iconic, that's everywhere. Whenever anyone says marijuana or cannabis, they show the leaf. They don't show the flower, the inflorescence. They show the leaf. And I just assume you smoke tobacco leaves. I guess you must smoke marijuana leaves. So for the longest time, even as I'm telling patients to, okay, because some of my patients, they can't afford the gummies. They come from a poorer neighborhood, and maybe they can buy some of the cheaper flower products out there to smoke. But gummies, and you start get a little bit expensive. And I would tell them, I would say, okay, use the loose leaf. And none of them corrected me. As I would tell them to take the leaves and tell them how to make butter about it. Now, I never actually put that in the medical record that I taught them that. And I would tell them to put it in to cook it in butter. And that there's a lot of recipes online because I didn't have time in the clinic to like download the recipe and share it with them. But I said, go online, get yourself a good can of butter recipe. And that way you can do it edible, but you don't have to pay extra and the premium for it to be a gummy. But yes, I use it for over 30 years against chronic pain, 10 grams a day. My roommates have MS and use about a gram dab per day. Could tell you so much about it. Now, MS, yeah, I mean, MS for sure. That's like of all the medical conditions, there's probably the most evidence about MS, especially the pain of MS. And then there's increasing. I was shocked. There is this organization called Cochrane, and Cochrane is a group that actually looks at all the data and it makes summaries and says, this is what evidence says about something. And this is what the data is, and this is what the research, it's very evidence-based medicine. And if there isn't enough articles to support something, Cochrane will not endorse it. So a lot of things that we consider mainstream, when you go and do the Cochrane stuff, people will say, no, and they'll often put it in a way of saying, there isn't enough evidence to support this use. Further research is needed. Cochrane actually did a meta-analysis about chronic pain and said there may be some evidence. And I was like, wow, that's high praise from them. It's still not, um, it may help. I'm like, wow, from those guys, that's high praise. So I think there's really some evidence that chronic pain can help. And, the thing is, when we look at things that can help pain, when you start talking about like opioids, even ibuprofen, right? Ibuprofen's a great anti-inflammatory. It helps on the COX. It decreases swelling in the body, but it can cause ulcers. It can cause kidney disease if you use too much of it. Um, Tylenol. Obviously, everyone now knows that Tylenol you can't take too much of, right? Everyone should know that. When it says only take 2 tablets, 2 extra strength, and no more than 3 grams a day, that's 6 extra strength in a day. I think they did increase it back to 4. There was a little debate. I would say if you're older and frailer, you probably shouldn't take more than 6 extra strength tablets of Tylenol in a day, because Tylenol can, if you overdose it, cause liver failure, fatal liver failure. I actually once saw a lady in hospice, and it was really sad because she was old and she had dementia, and she probably just forgot that she was taking them and was just pounding them. It turned out, at least we were kind of able to piece that together. The but she came in with nausea and vomiting, which, they thought, okay, little stomach flu. But then 2 days later, she went into massive liver failure, and everyone went, you know, and she died from that. So yeah, when we talk about pain medicine, I think cannabis is a fair thing to talk about because it can help. Now with MS, here, let's see. Phyllis is saying her gummies were actually reasonably priced through the Texas program, the original, and that's good, you know. And that's fair. In Illinois and their medical stuff, I've heard that a lot of their gummies are fairly reasonably priced. Um, but I work companies Texas Original where I get my stuff from. Okay. Are they in the Texas dispensary, or are they a hemp-based company that sells the gummies? Um, the 33 chronic pain. Now, is that 10 grams a day? Did I hear that right? I mean, some people need a lot. In my experience in the medical world, again, I'm dealing a lot with palliative, older people, people at the end of life. I often find that beyond 40 milligrams, doesn't have, you start getting more side effects than benefits. But again, I'm treating a lot of older people. I'm treating a lot of um, a slightly different population. So, yes, Texas original. So, yeah. Oh, You know, the other thing I think that doctors, here's their site. Oh, thank you. I'll put that up there for a second once we get it here. The, yeah. Now, I see we have a couple people with MS on here. What's your experience? Has it been mostly just pain that it's helped, the spasticity, or do you find that it actually helps other things for you besides just the pain? The data has always been about spasticity. Now, it's interesting because the um, texasoriginal.com. Okay, so the data about MS is really more pain spasticity. Interestingly enough, the people who do cannabis research, the Stativex, the European group that does cannabis research in um, where they have the sublingual spray of 1-to-1 CBD THC. They're approved in Europe for MS, and they tried getting FDA approval in the US, but their study failed. But it was really weird because they had some odd endpoint. Instead of looking at pain, they looked at like inflammatory something or another. I have to look it up again. It's been a bit since I read it. Um, yes, I've actually heard that with MS, when I was doing some studies about with sleep, that people with MS actually do sleep better at night when they have it, when they have MS. And I think part of it's the pain, but I think sleep is so tied to the endocannabinoid system that it's not surprising. And we know that MS, in rat models of MS, the endocannabinoid system is broken. That's how they have rat models of MS. And it's not surprising because oligodendroites, which are, myelinated cells and whatnot, the stuff that makes the myelin. And for those of you who don't know, um, myelin is this coating on cells that helps them move better. Not cells. My tongue tied. I apologize. On neurons. So neurons in the brain, you have white matter, myelin. It's a little fatty coating on neurons that helps the electricity move through the cell faster. And so, as a result, if you have good myelination, that transmission from point A to point B, from your brain to your fingers, is going to be very fast. Something that's demyelinated is going to be very slow. A very a good example of where you might feel this is if you hurt yourself, if you burn your finger on a stove, that sharp pain is actually through alpha delta cells, and those are myelinated. And so that means it goes fast. It actually does a couple things. It goes to a reflex center that then comes back that say, hey, move your hand off that burning thing. So it doesn't even go to the brain. You reflexively take your hand off the burn. Then through those myelinated cells, it goes to the frontal lobe of the brain, the parietal. It tells you how sharp, ooh, burning pain, 7 out of 10. And then it tells you, no, hey, let's go do something about that, like put some cold water on it. Now, while you're walking to the sink to put some ice or cold water on that burning finger, now you start feeling a throbbing. That throbbing is C cell functions, and they're not myelinated, which is part of the reason it took a couple seconds longer. Well, one, the inflammation had to kind of build up, but two, it actually does take a little bit longer for you to feel inflammatory pain. But once you feel it, it's there because it also creates a feedback loop where it then causes the release of more inflammatory factors, which then causes more pain. Now, there is a whole thing in chronic pain where we find that that loop has messed up. And now it's creating pain even if you don't have an injury, or you had an injury, but now it still creates pain. And those chronic pain syndromes, they think is a mess up at the feedback loop. There's actually a relay point for pain right in the spine So it goes from the extremity, then to the spine, and then from the spine up to the brain. There's a little connection. And in that relay point, they think the feedback loops are messed up. And there's some thought that cannabis might actually help with that. So that's part of the reason we think that cannabis might help chronic pain. And that's pain that's been there for a while. It might even help inflammatory pain. Inflammatory pain's a little differently. That's those C fibers. But it does, one thing cannabis doesn't seem to help too well is acute sharp pain. So that's kind of what it doesn't seem to help. So acute sharp pain is like, is that burn? Is the cut? So it's not going to help. We get a lot of mixed studies about post-surgical studies and like, does it help with pain? And it's kind of like, eh. And even cancer pain data. Oh, we got a bot from Twitch. Okay. The so we have even cancer pain has a lot of pain. What am I trying to say about that? Even cancer pain doesn't seem in the studies to respond very well to cannabis. And again, I think that's because they're not separating out the acute sharp pain. If you have a tumor or something, and anytime you touch that tumor, it hurts, that's sharp pain, that's acute pain. If you kind of have throbby, achy, yeeky pain, that's going to be more inflammatory, and that might respond a little bit better. But to be honest, that might respond better to dexamethasone or ibuprofen or something, the inflammatory pain. The acute pain is probably going to respond a little bit better to morphine. And then anything that's kind of developed chronic or emotional pain. So if someone is going through a lot of existential suffering because of the cannabis, or not cannabis, sorry, tongue-tied again. It's doing that. A lot of existential pain because of cancer. Cannabis might help you feel a little bit better because it makes people some people might emotionally feel better. So that's kind of where that works. Now, I'm going to go back to some of these questions. Kim Nicole says Bermuda Cannabis Association is creating conversations around this very matter. This is wonderful. I'm so glad you like it. Yeah, I'd love to talk to them more. Thank you. But yeah, we need so much more conversation about it. The other thing, let's see, Phyllis chimed in. She was diagnosed at 28, not many treatment options, and you were in denial. And then with the age, the symptoms worsened. I'm 69. Okay. Oh, so you get the infusion center. And then the cannabis helps you. Yeah. I mean, I'm glad it's helping. I'm so sorry you went so long in denial and you had so many symptoms before then, but I'm glad you're feeling better now. Oh, we clicked on that. Oh, thank you. Thank you, Allison. Glad to hear it. And then, oh, hey, Dr. Jennings. Nice to see you. Thank you so much for your insight. And thank you. Appreciate it. A great breakdown. So, a little bit of something while we talk about that is as we start to wind up in the last few minutes, I wanted to talk about things that are going to be changing a little bit with the channel. I'm still going to be here on Wednesdays at 3, but I got a feedback that there's a lot of, I have a theory that there's a lot of people who cannabis might not be safe for work, right? They can't talk about it in the work hours. So I am going to be adding a Thursday evening chat. And I'm thinking I'm going to do it 7 Central. Let me know if you think a different time might be better. But the way I figured I'm Central Time, if I do it 7, then that's 8 Eastern and it's 5 Pacific. So people on the West Coast are just getting off of work, may not be home quite yet. But I figure if I do 8, then people in the East Coast are going to be wrapping up for bed, and that might be too late for them. So I'm going to try to kind of figure that out, but I want to add I'm going to be continuing to have this one on Wednesdays, but starting next week in August, on Thursday nights, I'm going to have an evening one. And that's for people who are possibly needing to be able to talk about it, but can't talk about it at work. Or maybe they're actually, do a job that they can't do a lot of they can't break away for an hour to be on the podcast. And this channel, the way I do this, while I can certainly talk, I could filibuster if I needed to. If we ever have a law that they want to ban everything and stuff, if you ever need someone to filibuster, I'm your girl. I can talk and talk and talk. But really, you guys are the co-stars. You guys are the ones, the interaction with you guys, the questions, the conversations. This is what makes this channel great. There's a lot of podcasts where people will just talk to another person or just talk and talk and talk. What I think really makes it special, what I really enjoy, is when people chime in and start commenting on their experiences and thoughts. Yeah, I start off the first 15, 20 minutes talking about something because I know people have to kind of warm up to that. But I want people to be able to express themselves. And I want this to be a community of people that we talk to. So, yeah. Anyway, thank you guys all. It's about 3 more minutes. There's a little bit of a lag if you're watching on LinkedIn. So, just so you know. But does anyone have any other questions as we talk here today? Anything? Let's see, just a couple the highlights. See, Phyllis says 7 Central works for her, so that's good to know. Okay, at least one vote for 7 Central. Best medicine against MS. I would argue that some of the meds that they have can be extremely useful for MS, but I would also argue that if you have MS, because we know in the animal model the endocannabinoid receptors are broken in MS, that in my opinion there's another disease, Parkinson's, where the dopamine receptors in the brain are broken, and giving people dopamine helps them move and helps their symptoms feel better. L-dopa, it's actually a type of that can cross the blood-brain barrier and get into the brain. Giving people with MS cannabis is the moral equivalent of giving people with Parkinson's dopamine. You would obviously give people, I mean, unless they, of course, had some strong reason not to, and certain disease states of Parkinson's, you may say, okay, at this point we can't. But generally speaking, for the most people with Parkinson's, you're going to say, we need to give you dopamine. If you have MS, you probably should be using cannabis. And I think it can help. And again, there are people who it doesn't help. But that's again where the conversations with your doctor can be very useful. Let's see. Yes, in summer, 5 grams. In winter, 15 grams. On average, 10 grams. See, as a doc, that blows my mind a little bit just because it's so high of a dose. And I would be talking a little bit about, if you were to come to me and you would tell me how much you took, we would be having conversations about, is that helping you? Do we need to talk about tolerance breaks where maybe are you just developing such a high tolerance that you need to take that much? Or is the medical condition that you're treating it for so bad that, yeah, you need that much? I know in the opioid world, I have people on 200 microgram fentanyl patches, and sometimes these huge doses of I'm sorry, I was reading your comment there. Yes. But I sometimes see people on these huge, huge doses of opioids, especially in the hospice and palliative world where someone has cancer. Yeah, you need a high dose. Though, again, you would have a talk with your doctor or a cannabis specialist. Just make sure you're not using it as that you're using it to actually treat the pain and that you haven't developed such a high tolerance that maybe a tolerance break. And again, Dr. Sulak has a whole protocol he developed that I've heard a few people swear by. Um, Statistics. You know what? I wouldn't even know because the truth is that in Europe they have it, and it's still not in the U.S. because we still can't get cannabis for medicine in the U.S. and it is crazy when there's so many people who need it medically. That drives me crazy. I do support a group called the Americans for Safe Access. They are about creating medical cannabis. They're only for the medical arm. So if you're more recreational, that's we'll still support the medical people, right? But they're about making it its own schedule. Instead of making it Schedule 3, they would create a new schedule called Schedule 6 just for cannabis and have rules just for cannabis. And personally, I think that makes a lot of sense. And so, wow, hey, our time is flown. It's 4 o'clock now. It has been great talking to everyone. I hope everyone has a great day. Oh, yes, sleeping better, no cramps, less inflammation in brain and spine. Now, that's a whole other thing, and I'll just say that real quick, is that there's actually some question about whether it can help slow the progression of MS. And the data isn't there. Anecdotally, you got a lot of people with MS who use it and swear that they are better and that they don't have as much progression and they don't have as much symptoms. So, yeah, if it helps you, I'm not going to be angry about that. So, anyway, I will see everyone back next Wednesday. And then again, starting next week, I will have a Thursday evening at 7 p.m. Central. I'll be adding that so that if people are at work or see if people can show up, and we'll see how that goes. It has been great seeing everyone. I see a bunch of new faces today. It is so exciting. I hope everyone has a great day and enjoy yourself and stay cool in this heat wave. Bye bye.